Hi all. So today we will be seeing about spine examination, and I am Dr. Sudhir. I am an orthopedic spine surgeon. The moment we hear the terminology spine, especially as a student, this will be our reaction. So it's just like the scared baby. The moment we hear spine, or when we get a spine case in our examination, we tend to run away from the case. So I hope today's session will give us an insight about the examination of spine, and you will get a clear idea about how to approach a case when you are being given in the exam. So first and foremost thing is the history. Just like in any other case examination, history is very important, and especially when it comes to low back pain. As a practitioner, not only as a student but as well as a practitioner or as a surgeon, out of 10 patients whom you see in your OPD, at least 6 to 8 of them will have low back pain. And these low back pain can be sorted out in various boxes. The first and foremost, or the commonest type of low back pain, is called as the mechanical low back pain. So how do you sort these types of pain in the history? So in mechanical back pain, the patient will classically say that their pain is worse in the evening. As the day goes on, especially in the evening and night, the pain gets worse. So that is mechanical low back pain. The second common type of pain is called as the instability low back pain. So we all know whenever there is an instability in the spine, the pain will present predominantly when the patient tries to turn in the bed, or when the patient tries to stand up from the sitting posture. This is called as instability back pain. The third box is the degenerative type of low back pain, which is again a commonest type of low back pain. And this type of low back pain, especially when there is a degenerative disc disease, the pain will be worse after activities, and usually it will be associated with a radiating type of pain. We'll discuss what is radiating pain in the next slide. It is basically because of compression of a particular nerve root. The next type of pain is the inflammatory pain, and this kind of inflammatory pain usually is associated with inflammatory pathologies like rheumatoid arthritis or other seronegative spondyloarthritis. And this is classically an early morning pain which will be associated with small joint pain and polyarthralgia. The final type of back pain, the type of pain which is associated with trauma or tumor, and this is classically presents at night, and these patients usually have associated constitutional symptoms like loss of weight, loss of appetite, or associated with fever. Now, whenever we elicit a history of pain which is radiating from one part of the body to the other part of the body, we usually get confused whether it is a radiating pain or whether it is a referred pain. So how do you differentiate it? Classically, the radiating pain will start from the back and it will travel all the way down to the leg or to the ankle. So the image on the right side is an example of radiating type of pain. It is basically because of compression of a particular nerve root or a radical, and the pain travels along the entire course of the nerve root. The classic triad to diagnose a radiating pain is it should be along the posterior aspect of the thigh and along the posterior aspect of the leg. Any pain which comes along the anterior aspect of the thigh or leg is usually not a radiating pain. The second point is it is always associated along a particular dermatome. As I said, it is because of involvement of a particular nerve root, and hence the pain will pass along a particular dermatome or a particular nerve root. And the third point is almost always it has to cross the knee joint, because this radiating pain is usually along a particular nerve root which forms the sciatic nerve, and as we all know, the sciatic nerve travels from the back to the ankle and it supplies the entire lower limb musculature. So it has to cross the knee joint. Whereas the referred pain, whether it is because of a facet joint pathology or because of sacroiliac joint pathology, will usually be present only up to the buttocks or up to the posterior aspect of the thigh, especially only up to the upper third. This is how we differentiate a radiating pain versus referred pain, and it is very important to differentiate these two, which will give us an idea about the pathological area. Now, the history in case of spinal deformity is slightly different. You have to start with the onset of deformity, the progression of the deformity, and whether it is associated with any pain or not. Regarding deformity, we will be discussing the spinal deformity in detail in a different module, but here the one point which you have to remember is the antenatal, natal and postnatal history is very vital when we are dealing with a deformity patient, especially even when the child is about 14 or 15 years of age. It is always important to know the antenatal, natal and postnatal history. And the final thing is the treatment history. Again, it is very vital when we deal with a spinal deformity patient. Now, since we are going to concentrate about the spine examination, you have to understand that examination of spine consists of two parts. First is the examination of spine per se, which belongs to the skeletal system, and second is examination of the spinal cord, which belongs to the nervous system. That is one of the reasons why most of us are scared when we are dealing with both the systems at the same time. But I hope this should not be taken very seriously, and if we go methodical, there won't be any issues. So when it comes to inspection, just like any other examination, the spine examination also has inspection, palpation, movements and measurements. The predominant portion of the examination of spine is from behind. That is, you have to stand behind the patient and you have to carry out your examination. The first and foremost thing is inspection from the back. The most important thing which we have to understand is the spinal alignment. The spine is one structure which is responsible for all of us to stand erect, and our body takes immense care to make sure that the head is centered over the pelvis and an individual is standing erect. So you have to look for the position of the head, whether it is centered over the pelvis or not. The position of the hairline to rule out any congenital anomalies, whether it is a low hairline like in Klippel-Feil syndrome or whether it is a short neck, and the level of shoulders, level of scapulae, level of iliac crest and the level of dimple of Venus, which corresponds to S2. All these levels are very important, especially when we are dealing with the patient with scoliosis. Again, whether there is any spinal curvature which is present or not. Then comes the lateral margin of body from the axilla to the iliac crest. That is again very important to look at, especially when you are dealing with scoliosis.